where they work together. They don't do the same thing, but they are going to share roles. So in reproduction, there are 3 E stages. This is for free. Okay. One is erection, and most of you are familiar with penile erection. All right. The clitoris also becomes erect. It's just not as large. So the same structures, events, blood vessel dilation is going to occur. Then there is emission. And emission is the movement of the sperm and the secretion of the seminal vesicles in the prostate into the urethra. Okay, females don't have seminal vesicles. In 2002, it was decided they had homologous structures to the prostate gland. So there is some emission in females into the female urethra of a mucus-like secretion. And then ejaculation, which there is both skeletal and smooth muscle contraction, primarily in the male, to move the sperm out of the urethra. All right. So, again, this is to illustrate how these work. So, emission. Let me do ejaculation first. Erection first. So, erection is a change in blood flow. And this is affecting dilation of blood vessels. So blood vessels dilate, more blood flows into the penis or the clitoris, and that compresses veins so it can't flow out. All right, so typically vasculature is done by sympathetic nervous system. In this case, it's done by parasympathetic. So this is dilation of penile or clitoral arterioles. And it uses acetylcholine and a gas, nitric oxide, as the neurotransmitters. Okay. So erection. Emission is done by the sympathetic nervous system, primarily. A small amount is done by parasympathetic, but the major role is sympathetic, and this would be glandular secretion of seminal vesicles, prostate gland, in the male, paraurethral glands, female, and vulvourethral glands in both. These two are considered to be homologous structures, just like testes in the male, ovaries in the female. All right? And then ejaculation is back to parasympathetic. So this is peristalsis. There's skeletal muscle involved, but obviously that would not be autonomic. So peristalsis of urethral, that's the tube that carries urine from the bladder or sperm, urethral smooth muscle. Okay, so this is collaborative. So rather than being opposite effects, both parasympathetic and sympathetic are needed for all the events to occur. They do separate things, but they're combined for both events to occur. If someone had a spinal cord transection at T10 and was no longer capable of feeling stimulation from the penis, the tip of the glans penis or the glans clitoris, would they be able to have an erection and ejaculation? Yes. Yes. All right. If it's below L2, they wouldn't do the emission quite as completely. All right. So getting their partner pregnant may not work, but they could still have the erection, they would not feel it. But this is sometimes after the initial shock and the gross part of it is over, can be very important to a couple, all right? Or to the male or the female, even if they're not in a couple relationship yet, to know that they can still have sexual intercourse and pleasure their partner, even if they themselves may not be able to feel anything. They reflexively can still have an erection, can still have an ejaculation. And if they're male, then can still make a female partner pregnant. That's their desire. Glands, yes. Bulbo urethral glands. They should have an L in there, sorry. Yeah. Okay. Then the last part we're going to talk about is where sympathetic does it all by itself. Okay? That we change the effect by either increasing or decreasing the sympathetic's role. So this is going to be primarily vasculature. So blood vessel diameter, either constriction or dilation. It's going to be all sympathetic except for the penile arterioles and the clitoral arterioles. All right, so it's unusual for those blood vessels to be affected. So with constriction, we just increase the amount of norepinephrine and the frequency with its release. With dilation, we accomplish it not with a different neurotransmitter, but by just decreasing the amount of norepinephrine that is released. Now let's take a look at the receptors for and the neurotransmitters from the autonomic nervous system that is sympathetic. So on your lecture notes, it's 119, I think. No, not 119. Yeah, the alpha and beta receptors. 93. Okay. I knew there was a 9 in there somewhere. So 93 shows a list of the receptors. And shows the neurotransmitter. Can I erase this board now? Okay. So if we look at the first possible pathway that we described on Friday, that I described for you, remember we had a short preganglionic neuron, which came out here to the autonomic ganglia, and these would be our paravertebral ganglia, forming the chain along the side, what superior, middle, and inferior cervical belong to. Those are paravertebral ganglia. So this would be the preganglionic neuron. Is it myelinated or not? Yes. And the neurotransmitter released acetylcholine. And then we would have the cell body of the postganglionic neuron, which would have a longer axon and end up in the skin. Okay. I'll make this a little bit bigger here. So our neurotransmitter at the ganglion at the ganglion is going to be acetylcholine. So if you recall, the preganglionic sympathetic and preganglionic parasympathetic all release acetylcholine. What type of receptor is present in the cell body of the postganglionic neuron for acetylcholine here? Is it nicotinic? Do you recall from the previous diagram? Is it nicotinic or muscarinic? Muscarinics are always G proteins. So this is nicotinic, and it's ionotropic. Nicotinic just means the type of acetylcholine. All nicotinics are ionotropic. All right, so when acetylcholine binds to it and opens the ligand-gated channel, does it have an excitatory or an inhibitory effect, or does it depend? What's the ion that passes through? It's always sodium. So if sodium is a positive charge and it goes into the cell, it's always going to be excitatory. Okay? It's going to form an EP-SP, always, whether it's parasympathetic or sympathetic. Okay? Hopefully you're understanding more and more of this as I say it over and over. It's starting to make a little bit more sense. All right. In the skin, we have two different neurotransmitters that are released. If this first neuron is releasing at a sweat gland, what would its neurotransmitter be? Remember? The one exception, acetylcholine. So this is the one time that a postganglionic neuron does not release norepinephrine. All right, so this is our postganglionic neuron, sympathetic. Not myelinated either. At the sweat glands, it's going to release acetylcholine, and these are also going to be the same as this, excitatory, nicotinic, ionotropic receptors. Unlike the postganglionic parasympathetic, which are the muscarinic receptors. So this is nicotinic. So being a nicotinic receptor, everything else I wrote up here is the same as well. All the other postganglionic neurons for the sympathetic nervous system, whether they go to blood vessels, whether they go to cardiac muscle, whether they go to glands, are going to be releasing norepinephrine. These are going to be releasing norepinephrine. That one exception is at the sweat gland. So this would be to smooth muscle in the eye, smooth muscle in blood vessels, cardiac muscle, and glands, whether it's the pancreas or the lacrimal gland or whatever. So here's the postganglionic neuron, and it just kind of floats over the structure. It doesn't form real tight synapses. So it's hit and miss whether the neurotransmitter, when it's released, actually happens to land on a receptor. It's not a very closely regulated. We don't have the really close presynaptic, postsynaptic membranes that we're used to in talking about a component. And there are two different types, as I wrote up earlier, there are two different types of receptors. Alpha receptors and beta receptors. Now there's two of each, alpha 1, alpha 2, beta 1, beta 2, and there's actually more than two beta. There's beta 3 and to a lesser degree a few beta 4 and beta 5s are being described, but predominantly beta 1, 2, and 3. We're just going to look at alpha 1 and alpha 2 because that's all we really talk about next semester. Again, the post-ganglionic cells, neurotransmitters, are going to bind to receptors that function as G proteins. As G proteins, they may have an ionotropic effect, and in other words, they may open an ion channel, but secondarily. Okay, the receptor itself is not an ion channel. So just like all of our muscarinic receptors binding acetylcholine were G proteins, all of our effector, our muscles, our glands binding norepinephrine are going to be G protein regulated molecules. All right. So alpha 1 and beta 1, if you want a rule, and of course every rule can be broken, but typically alpha 1 and beta 1 are going to be excitatory, and alpha 2 and beta 2 are going to be inhibitory. All right, even though they're all G proteins, the effect is going to be different. So these are all metabotropic. I haven't figured out how to get my computer to make the Greek letters, so I just write these words out on an exam or on the quiz rather than write them out. So alpha 1 receptors are, you have a picture here, are G proteins. The receptors, so the G protein is going to separate the alpha subunit. It's going to activate a membrane-bound enzyme, which is going to split a lipid into IP3, and that's going to cause calcium stored in membrane sacs to be released. That calcium can then act as a second messenger, or if it's in a smooth muscle, the calcium is going to expose binding sites and allow muscle contraction. All right. So alpha 1 receptors are going to cause muscle contraction. We see them primarily in blood vessels. And they're going to cause the contraction of the sphincter muscles. So the bladder sphincter muscles. So they're going to make that bladder less likely to leak. So it's not so much that they're excitatory in that they result in a depolarization of that cell as they result in that cell actively contracting due to the exposure of calcium. Okay. That should be ionotropic. No. So the ionotropic effect is not, that it is a ion channel, but that it subsequently will allow ions to increase in the cell indirectly. Alpha 2 receptors are inhibitory. They work on cyclic AMP. So they're going to cause relaxation if it is a muscle they're binding to, or decrease secretion if it's a gland that they're binding to. So this is going to decrease levels of cyclic AMP, and that results in a decrease in the enzymes that are active, as well as a decrease in calcium, and it's a whole cascade, as you've seen before. So alpha-2 receptors will result in dilation and lower levels of excessive cyclic AMP. Again, some of the basic pathways that we've already talked about. It's just another G protein, but its effect is different. It has an inhibitory component. So we're not activating cyclic AMP. Okay, beta receptors are primarily all cyclic AMP. So beta 1 is excitatory. So this is going to increase cyclic AMP, and it also increases calcium ions. This is what works on the heart, by the way. So when we increase heart rate, it's because norepinephrine is binding to a beta 1 receptor. Our alpha receptors tend to be blood vessel and glandular primarily. Beta 2 is inhibitory. It's going to decrease cyclic AMP and decrease calcium ions. And this is what we find in the airways of the lung. So when my oldest son was playing soccer, he hated to run. He likes running now, but he hated to run. And so his favorite position was playing goalie. He was tall and he was good at it, but he didn't have to run. Unfortunately, one cold November day, they had 2 games scheduled in the pouring rain, and neither of the coaches of the 2 teams would be the first to cancel a game. So I had brought along a rain jacket for him, but you know the goalie has to wear a different colored uniform so they know he's a goalie, and my rain jacket was the same color as everybody else's shirts, so that coach wouldn't let him wear it. So he wasn't running like everybody else was staying warm. He got to stand there in the rain and be cold. But it was still his favorite position. My husband would give him, he had allergies to cut grass and stuff like that, and so he had an inhaler that he would use occasionally. And I didn't realize it at first. My husband would give this to him before a game. And I'd say, well, honey, he's not having, you know, any breathing problems. He goes, I know, but it gets his heart rate going before the game starts. However, even though that is a side effect to inhalers like salbutamol, the receptor is different. If it bound to the same type of receptor, beta 1, then every time you took an inhaler, you would have a heart rate of like 130, all right, to 150. Is that me?
Yeah. You're on the door.
Probably my husband calling back. Can I take this for just a second, guys?